One of the main things that a lot of this diagnostic testing and things is going to be based on is the types of tissue that are involved. Right? There's different, it's based on something named Syriac, which is kind of like the godfather of orthopedic medicine. Right? It's a British guy that was, I think, starting in the 20s, 30s, 40s, something like that. And he talked about different types of tissue and divided it mostly into inert tissue and contractile tissue. And those are all mentioned into here. But also kind of differentiated where you have inert tissue, contractile tissue, you have nerve tissue, and vascular. So a lot of times we're going to talk about, if you talk about a test, you say, well, what kind of tissue are you testing? Are you testing contractile tissue, inert tissue, neurologic tissue? Because the tests are going to be done differently depending on what type of tissue that you're evaluating. So if we start with inert tissue, basically it's going to be bones, ligaments, cartilage, things that are just inert that aren't doing any contracting, basically. They're not contracting, they're not conducting any nerve impulse, they're not having blood flow through them. Although in some cases, if you just talk about inert tissue, neurologic tissue a lot of times will come under, actually it comes under contractile because you have to have a nerve impulse to make a muscle contract. But for purposes of this class, we're going to separate them out. So the inert tissue is going to be bones, cartilage, joint capsules, ligaments, fascia, bursa, and cartilage and the dura mater. So the way that you're going to evaluate those are basically going to be compressing things. If you have a joint problem, let's say you're evaluating this joint here, you're going to compress on it like this. Or if you're evaluating the ligaments, you may be stretching the ligament, doing things to apply force to the ligament. And then the way that the type of symptoms that you're going to have with that are going to be more deep, nagging pain. It can be sharp or dull. There may be some deformity. If you break a bone or you sprain a ligament, you're going to have some deformity. There can be some joint locking, there can be swelling, and the weight bearing can be affected.
It says inert tissue is tested by passive range of motion?
Right. So, yeah, so that's what we're going to get into. Let me just catch up here where we're at here. All right. So when we talk about range of motion, we'll get into range of motion more later, but you have active range of motion, passive range of motion, and active resisted range of motion. Active is where it's all in relation to what the patient's doing. Okay? If they're actively moving their joint, that's going to be active range of motion. All right? And this is listed later on in the notes, but just for now. So then passive is where the examiner is moving the joint. And then you have active resisted range of motion is where the patient is resisting range of motion. All right? So which one of those is going to use contractile tissue? Active range of motion or passive range of motion? Exactly. So active, right. Because you're actively contracting your muscles to do the range of motion. So passive range of motion is where, can you get the skeleton? Passive range of motion is where the examiner is going in there and moving the joint. So you're doing things to assess the joint without utilizing the muscle. Okay? So you're going to take the joint and move it and do different things. So you're going to do passive range of motion, and then also you're going to evaluate inert tissue at the extreme end of range of motion. So if we talked about the shoulder dislocation, this is kind of more of the extreme end of range of motion for the shoulder. So we're putting it in that position to evaluate the inert tissue. And then also, you can either compress or distract joints to do. That's on backwards. And then when we talk about, now I'm putting together a list, I don't have it completely done yet, about these. You're going to see a lot of these things, which are called TLAs, which is 3-letter acronyms. You got MOI, which means, anybody know what that is?
Mechanism of injury.
Right, mechanism of injury. There's a whole bunch of them. There's going to be DJD, DDD, all kinds of stuff. So at some point we'll have a list that has all the different ones so that you can know what they are. But as we go, you can write down what they are. So mechanism of injury, we'll talk about that. Everybody know what that one is right there, right? Range of motion. Okay. So when we talk about mechanism of injury, you're either going to have acute injuries or chronic or repetitive injuries. So most of the time, inert tissues are going to be affected by acute injuries. As you think about it, bones. How do you injure bones? You break your leg, it happens like that, right? It's not. You can have compression fractures or overuse fractures where gradually you can have trauma to it. But usually it's going to be acute. When you sprain your ankle, it's a one-time acute traumatic thing. Stress fractures, that's the other thing. You can have a stress fracture that can occur as a repetitive type of thing, but most inert tissue injuries are going to be acute, and most contractile tissue injuries are going to be repetitive types of things. If you have this muscle strain or tendonitis, those tends to be repetitive or acute. You can have an acute muscle tear, but a lot of times contractile tissues are going to be repetitive injuries. So again, then the symptoms are going to be deep, nagging pain, sharp pain. You can have deformity, swelling. The joint can be locked, and you can have limited or non-weight bearing. Then contractile, we talked about muscles, tendons, and their attachments. So again, contractile tissue is something that's going to contract. And so then we mentioned before, you're going to test them by what? Active range of motion.
What was DJD?
Degenerative joint disease. And then here's another one. Can you take a guess what that is? Active resisted range of motion. Okay. And then PROM is passive range of motion. Active range of motion is AROM. And I think that with that number 2 there, I think it's one of the references at the back of the notes. So again, like I say, for mechanism of injury in contractile tissue, it's usually going to be repetitive, overuse types of injuries. Tendonitis, tendinitis, tenosynovitis. You can have some that are acute, but most of the time it's going to be repetitive. And then for muscle type of an injury, everybody's had like a muscle cramp or a muscle pull, something like that. So you can have cramping, pulling, dull aching, pain with use or with exertion. Okay? So like I say, if we're examining, if we're testing at contractile tissues, we're exerting the contraction of the muscle, and that's when it's going to reproduce the pain.